And live! We are live!
Brilliant. Hello, everyone. Welcome to the Cancer Conflict Facebook Live event. So why are we here? First of all, well, we're here because this marks the middle point of our crowdfunding campaign, which is really exciting. We've in just over 2 weeks, we've reached £15,500, which is amazing. So we're celebrating tonight by having a conversation with two very special guests, who I'll get to in a minute. But first, I thought I would go over the film itself. Is a film about the conflict that is prevalent at the moment when experiencing cancer, around the various sort of aspects on how best to treat it. And the two stories that we're following of Grant, who's chosen conventional treatment, and Surinder, who's chosen alternative treatment, are a platform for this really important conversation. And so tonight we're going to be having one of these conversations on a really fascinating topic, one that I think it just fascinates me. It's the placebo effect, consciousness, and the doctor-patient relationship. And for those who don't know what the placebo effect is, it's basically, in a nutshell, the placebo effect occurs when I give you a tablet that is sugar, but I tell you it's paracetamol. You take it thinking it's paracetamol, and you have the effect of paracetamol when it's just sugar. That's the placebo effect, yeah? And it's important. We'll go into it a little bit more. But a little bit about, before we get on to our guests, a little bit about the crowdfunding. I just need to clear up, a couple of important factors. David Bowie performance didn't happen. We didn't reach the 20K. There's a few reasons for that, but it's not to worry, because I've been set a new challenge. And the new challenge is that we want to reach 20K now by next Tuesday, which is, we need £4,500. And if we do, I will dress up as David Bowie, face paint and all, and I will bungee jump off the O2 and of the O2 dressed as David Bowie. That's what I'll do. If we get to 20K, I will do that, right? Face paint and everything. And I tell you what, I'll even sing the chorus, Ground Control to Major Tom, as I fly down the... I'm terrified of doing this, but I will do it. So that means we have to pledge. Get pledging. You want to see me, David Bowie, flying? That's what you've got to do. 4.5K. We can do it. I absolutely believe we can do it. So the other thing is, there's been a couple of questions I need to clear up. Two things, right? First thing is Kickstarter. It's a Kickstarter campaign, so we're crowdfunding through Kickstarter. It's not like Just Giving. With Kickstarter, we have to reach 40K. If we don't reach 40K, our target, we don't get anything. It's an all or nothing campaign. So the 15.5K that's already there, we don't get it. If we don't reach the 40K, it means that we won't be able to finish this really important film and have this discussion and get this discussion happening. The other thing is, when you pledge, the money doesn't actually leave your account. The money only leaves your account once we have hit the 40K mark. So just so you know, we're not earning interest off your money in the meantime. So it's just a stress. It's really important that we get, especially now at the we're at the halfway mark. We've got 15 days to go. Now is the time to pledge, and don't worry, your money's safe. Okay, so let's get to the good stuff. So I'd like to introduce you to our two guests, Vijay Murthy, who is an Ayurvedic practitioner and a public health researcher.
That's right.
And senior oncologist, Tim Benepal.
Hi.
From St George's Hospital.
That's right.
Hi guys, welcome. We're in the lounge room because this is this is the kind of space where you'd have dinner and you sit down and it'd be like, oh yeah, and you start sort of chatting about interesting topics. So it's really sort of relaxed and casual. That's why we're here. So why don't we start with you, Tim? I want to talk about your experience. Well, can you describe for me what's the placebo effect?
That's a very good question, actually. I'm not sure anybody's entirely clear of what it is.
Yeah.
It's a term that, from my side of the table, if you like, is incorporated into some clinical trials, whereby if people are receiving a particular medication and that particular medication is wanting to be given to the other arm of the trial, the patients are simulated to have the same process done, but are not necessarily given an active drug. And in some trials, that's double blind. Nobody knows who's getting the active drug.
Nobody, you mean like doctors don't know?
Doctors, patients don't know.
Right.
And in some trials, it's quite clear that people are being given a placebo, and it depends on the trial structure. So from a sort of conventional medical point of view, that is what the term placebo means. The placebo effect is a much greyer area, because that's where you start talking about what is the potential physiology behind thinking that you're getting a medication, and how does that make you feel, and does that have a real impact on symptoms, and does it actually make certain things better? And if you talk about pain, pain is a very open, wide range subjective issue. If you talk about a lump getting smaller, it's a little bit more focused, and so there's a spectrum of what you'd expect from potentially a placebo effect.
Right. Okay. Okay, so that's an interesting. So in terms of by physiology, basically, in a nutshell, how consciousness affects the body. Is that correct?
Yeah, to which I don't have a clear explanation, but that is one of many presumed reasons why, to a degree, people can demonstrate in their minds anyway that they've had an effect from a medication, even if it turns out not to be an active medication.
Right. But I mean, it's obviously significant enough for trials, clinical trials, to factor it, because trials are double-blinded. So that means that the patient doesn't know, the doctor doesn't know, so the knowledge of what you're taking has an impact. I mean, it must have, it must have enough of an influence for it to be that considered.
Well, if you're talking about double-blind trials, the whole idea is to take away the knowledge of whether you've got something active or not, and nobody knows. So that's meant to create a level playing ground. In a trial where you're not hiding the fact that people are not getting the active treatment, and you are giving them a sugar-coated pill, or you're not giving them that, then the thinking behind that would be slightly different, I think.
Okay. So Tim, just give us a bit of background. What's your job, and what made you get into becoming a doctor?
Oh, two very different questions. My job is I'm a medical oncologist, so chemo and drugs rather than radiotherapy. Yeah. And I work in South London. I've been doing that as a consultant for 10 years now. I specialise in treating lung cancers. Right. What made me become a doctor is a more complicated question for a whole host of reasons. But I guess as an immigrant to this country, I think part of it was my parents kind of were hoping that I would take on what was then regarded as a vocation. Right. There was a bit of pleasant background encouragement to do something like medicine or law back in those days.
Right, okay. And
which I don't regret.
You don't regret it?
No, not at all.
Right. And what's the most difficult part of what you do?
Right now?
Of being an oncologist.
Of being an oncologist?
Yeah.
I would take one step back and say the most difficult part right now is just working in the NHS. Okay. That supersedes being an oncologist specifically.
Right.
In terms of my actual clinical job, the difficult part, I guess, depending on what type of cancer that you treat, is after a while you do get a little bit of burnout, I think, from seeing people getting diagnosed every day. A lot of my patients will not live as in be cured, but they live for a long period of time. So that side of it can be difficult, but it can also be really very rewarding. But in all honesty, the difficulty now facing us in the NHS, whatever speciality you're doing, is the politics, the money. That's by far the biggest problem.
Why? What do you mean?
Because the money's been taken away month by month. We're expected to do far more for less and less money. People's expectations far exceed the rate of growth of the service, and even though you've improved the way things are done over a 10-year period, it doesn't meet what political and public expectations are.
And so so with that in mind, how important for you is the doctor-patient relationship?
It's extremely important. It's pivotal, without a doubt, and it's one of the reasons oncology particularly was a field that I went into, because that relationship differs depending on what speciality you're talking about. So for me, it is essential. Without that, the process doesn't work.
Why?
Because it is. I can speak from my experience in oncology only, but it is not a speciality whereby the traditional medical model, the carry-on doctor sort of model, where the doctor is standing above in the white coat and telling people that this is how it will be done, and everyone is listening and doing what they're told. It is a multidisciplinary approach, so the care of the patient involves lots of different people, of which the medics are only one part of it.
Mm-hmm.
Specialist nurses, dietitians, various support workers, counselling, psychological support, logistical support, and because it is a complicated field for which there is a lot of change going on depending on which tumour type you're looking at. Lung cancer right now doesn't bear any resemblance in terms of the treatment landscape to what it did 10 years ago. People are becoming more aware, people are living longer. There's no simple, straightforward, black and white decisions pretty much at all. Every decision has a layer of complexities which you have to factor in. No two patients are the same. And you can't sort of adopt a conveyor belt approach to medicine like you can, for example, in a walk clinic. I'm just giving you a random example. One patient might take 20 minutes of time to discuss what their issues are in the clinic. The next patient might take an hour and a half. And that's where you have this big variability. And if the patient doesn't trust you, and if you're not prepared to listen to what the patient says, then there is no relationship.
So that's an interesting factor, because I hear a lot of people talk about a problem trusting their oncologist, or feeling like they don't trust their oncologists. What's your perception of that generally among oncologists in your field? Do you hear that much? Or?
So it's difficult to answer that question objectively because I am an oncologist. In all honesty, it's not something that has been fed back to me personally in any significant amount. Within the group of oncologists that I work with very closely, and again this is my anecdote, it's not something that comes up that people are facing big trust issues.
Right.
Again, I'm not entirely clear what you mean by trust. Trust them in what they're advising, or just trust them as people, or trust the system. I don't know what that means.
Yeah. Well, trust them in what they're advising. Trust the system that they're part of.
Generally speaking, in my experience, people will generally trust what you're saying, not exclusively. But when they question what you're saying, I welcome that.
Yeah.
And I, to the best of my ability, will give them the reasoning behind what I'm saying.
Okay.
As well.
And just finally, Tim, mindset, a patient's mindset, and your experience as someone who is dealing with patients day to day, how important is a patient's mindset?
It's a subjective question to which I can only give you a subjective answer.
Yep.
In my perspective, it is very important. It is not the be-all and end-all. It is not a sole factor for people doing well or not doing well, but it's something that people talk about a lot, and I could quote till next week or longer patients who describe their own mindset as being, say, more positive and being more active where they can, and where people seem to have a better experience. But this is not a scientifically measured outcome of stress. In my personal just gut feeling, I think the mindset plays a part. The patient who goes home and takes to their bed and doesn't do anything the minute they're diagnosed with their cancer, for all sorts of just practical reasons, is more likely to have more difficulties than someone who sort of tackles the issue head on, tries to maintain as much normality in their life, because it occupies their mind. They do things, it's whether that's just a practical issue, being active and doing things and therefore not having so much time to think about it, whether it's more likely that you'll be less depressed if you're active and occupied than if you're sitting around ruminating on your illness, I don't know. But in my mind, those sort of things do play a big part.
Yeah. Okay, so I'll move on to Vijay. Vijay, you are an Ayurvedic practitioner and a public health researcher. Could you what's Ayurveda? Describe it in a nutshell to me as if I'm a 5-year-old.
Okay, so I think, Tim, you have really laid out the clear landscape of what we see as medicine. And if you look at Ayurveda, Ayurveda is a health model, which is holistic in the sense it takes into consideration the role of consciousness in as much as it respects genetics and epigenetics.
What's epigenetics?
Epigenetics is, okay, so there's been quite a lot of research recently which looks at how the choices we make in terms of our nutrition, our mindset, our lifestyle, our behavior, and the stress levels, how we respond to stress, all of it has an impact on expression or genetic expression. So some of the hormones may be upregulated or downregulated, which can have an impact on immunity. So what I see is Ayurveda is holistic, and while Ayurveda takes or recognizes the biomechanistic aspects of health, it just doesn't specialize in biomechanical way of looking at the delivery of health as that's the only way. So in public health, interestingly, which is what led me to actually become a researcher, because when I was an integrative doctor, trained in medical sciences and Ayurveda, I was very good at what I was doing, but I didn't understand research firsthand. So I was a research consumer, like most doctors are, but I had to become a researcher to understand that actually health models like Ayurveda, that's just an example. Okay.
So, in a nutshell, Ayurveda is a health model that takes a holistic approach.
Yes, and in medical science, what we look at as efficacy, which is what Tim has been talking about, there's a difference between efficacy and effectiveness. So when you look at efficacy, whether something really works in a controlled situation, like when you do placebo, double-blind control, effectiveness is whether that really works in real world. And when a patient walks into my clinic, the patient is not walking into my clinic with controlled situation. They come with the baggage. There are many things that impact on their life, their health, their lifestyle. What Ayurveda does is to understand the person who has cancer, as opposed to just treating cancer.
Right.
So it's much broader, therefore it's complex. Anything that's complex will need more than a mechanistic approach to understand whether it works or not. Interestingly, today, with public health research, with mixed methods research, we are starting to understand that there are many other models, along with biomechanistic models, to understand what works and what doesn't work.
Okay, so for you, how important is the doctor-patient relationship?
Absolutely. I was lucky enough to grow up in an environment where I was trained in scientific models or scientific method of understanding diseases, but at the same time I was trained to use consciousness, which is the healing effect or the therapeutic relationship between patient and the doctor. And in fact, there's been a very recent research which looks at how compassionate and ethically compassionate, not making wrong claims and kind of making unrealistic, positive sounding claims to patients, but if a doctor is ethically compassionate and does a consultation which is very positive, we have seen, research has shown that patients have much better clinical outcomes. I think Tim would agree with
100%, I would agree with that.
Really? So from your point of view, Tim, well, do you know much about Ayurveda and what has Vijay just said to you? What is that?
So that word Ayurveda is not something I've been particularly familiar with. The concept of the holistic approach, what Vijay has just defined, is very, very familiar to me. I haven't practiced that, as in I haven't been trained in it, but it's over many years of looking after oncology patients, it's become very clear to me that, as you said, you can't just look at a biomechanistic view of the consultation. You have to take all things into account and a positive interaction on both sides, without a shadow of a doubt, even in the immediate sense, in the next 2 hours after a consultation, can have a beneficial effect. And I agree with Vijay completely. I don't disagree with anything he's saying, actually.
Okay, that's interesting. What if I said to you, but there's no way to measure this? There's no way to measure it, there's no stat for it, clinical trials.
there is. That's the truth.
There's a way to measure that.
Yes, yeah. What it was interesting, Tim. You clearly kind of differentiated placebo as an arm within randomized controlled trials to measure the effect of regular treatment,
Yeah.
the degree of effect of regular treatment. But placebo effect is different.
Yeah.
Placebo effect is actually very helpful in real life situation, because placebo effect, as you said, is to do with the mind. So it's how mind can influence our neurophysiology. For instance, I can have an expectation. Let's say Tim, as my oncologist, let's say, I kind of feel that I trust Tim. Then my expectation that Tim is looking after me, he cares about me, actually has a neurophysiological effect.
And you can measure that.
You can measure that. And there has been a systematic review which looks at 22,000 patients and the difference between regular treatment and placebo effect. The placebo also was efficacious, yeah, but it wasn't as efficacious as the regular treatment, say in conditions like asthma, in chronic pain, in pain management during cancer and IBS. The difference between the efficaciousness was about 15%. But the real thing that we need to look at is, if placebo is effective to a lesser degree than the regular treatment, but is safer than the regular treatment, for instance, opioids, in pain management, if you are a patient and if you could afford a placebo intervention, would you choose a placebo which still has shown to have an effect for more than a year over a regular drug which has severe adverse effects? So the question, as Tim raised, this is not about science. This is about feasibility. This is about economics. And we are talking about two different things. Medical research is about generalization, whether there are chances of increasing the success of a treatment for the entire population. But when I see a patient, I'm looking at this individual, and this individual is expecting me to deliver a highly individualized treatment plan, where efficacy is one aspect of what I need to consider in the whole management of cancer.
Right. And Tim?
100%, I agree totally.
But what, you agree?
Yeah, no, I'll tell you why. Because the earlier on Vijay said, there's clinical trials and there's real world, and that is absolutely the truth. A clinical trial is a very basic set of parameters. You have a primary endpoint, you have a secondary endpoint, and they have to be very clearly defined. You cannot have 35 endpoints in a trial. In a trial, it doesn't work that way.
Yeah.
And there is this term that we use as well of real world medicine and clinical trial medicine, whereby you've got patients enrolled in clinical trials who are strictly recruited in the sense that there are very strict eligibility criteria, and the kind of people you put into those trials, do they really reflect what you see every day in your clinic? And the answer is no, they reflect a particular population. And the extrapolation of that clinical trial into this means that this is the right treatment for everybody is not how it works.
Right.
Because, as Vijay said, there are so many other factors in the real world that are taken into consideration that are not addressed in specific clinical trials. They ask a very specific question.
Right.
And they do not take into account these other factors.
That's really interesting that massive decisions are made. Tell me if I'm wrong, and this is totally someone who doesn't work in the industry, is just on the outside, coming to the doctor. But would it be safe to say in that case, and I've got to move on in a second, but if it was safe to say in that case that big decisions are made on what kind of treatments we get based on very specific things that leave out big factors, differentiating factors. Does that make sense?
It's cost effectiveness, basically.
Yeah.
So it's an economical thing.
Yeah, it's an
the clinical trial, happening or not,
Yeah.
and producing a positive result, in itself does not introduce a standard of care. There is then a very complex process that is almost exclusively based on cost effectiveness that makes that decision.
Okay, so I'm going to have to wrap it up in a second, but basically, what we're talking about here, you both exist within two different modalities of medicine. Tim, you've been trained from a science background from an oncology point of view, Western medicine. And Vijay, you've been trained from an Ayurvedic background, Eastern, is that?
Yes.
Eastern, but you've also got a science background as well. But what we're talking about are two modalities of treatment. But would you agree that there seems to be a connection?
There is, because it's never consciousness versus science. It is consciousness and science. That's how it works.
Would you agree, Tim?
100%. I would totally agree with that. To suggest that any one single modality or one approach is the only way to look at this kind of situation is nonsense.
Even though there might not be scores of statistical evidence to back what you're saying.
I'll have to stop you here. Statistical evidence is different from clinical evidence. Statistical significance is important for me as a researcher if I want to generalize this particular treatment to the entire population. Whereas clinical significance is entirely different. And if you really look at even placebo, what you have been talking about, there are 37 clinical trials on cancer patients where they looked at the role of placebo, and in about 375 of them, there was a placebo effect which was promising, which had an effect on tumor size. However, because it's only 3%, it's so insignificant in terms of the percentage that we don't have enough money or resources to study that rare phenomena.
Right.
So if we had enough resources to study rare phenomena, then we will not be looking at decisions on what is a standard treatment.
Tim?
I mean, on that last point, it's well recognised in cancer patients over many years that without any conventional treatment, their tumours have sometimes got better. And in some respect, that is partially hypothesised anyway to be explained by the immune system's effect on the cancer, which you not necessarily would argue is placebo, it's real.
Is that the get better anyway effect?
No, that's the immune system recognises the cancer as foreign and actually your body attacks it successfully.
Right.
So that's not a placebo, that's a real phenomenon that's now currently being explored. But that doesn't take away from what Vijay's saying. I'm only giving you one little example. That the actual true placebo effect, yes, Vijay's right. You know, it's not something that much time is invested into exploring in that group of patients.
But in a nutshell, there's a link here. We've got a link here. Yeah? They're nodding.
Yes.
They're nodding. We need to see. We need to hear. We've got one single camera. Interesting that there's a link. That's what I find interesting about this, and that's why I brought you guys together tonight to see if there was this link, and it seems like there is. There's more to be discussed on this, and we will discuss it in the film. We're going to go into this much, much more because it's a very, very important topic. But we've got to wrap it up because these doctors are highly in demand individuals and have got loads of important appointments to make. So we have to wrap it up. Thank you all for coming. Thank you for watching. This has been fantastic. Don't forget to pledge. Don't forget to... We are 15 days through our campaign. We've got 15 days to go. If we get $4,500 by Tuesday, I will jump off the O2, bungee jump off the O2, dressed as David Bowie. And I will sing Ground Control to Major Tom as I go flying down to the ground. I will do that. I'll do that for you. I'll do that for this film. And I'm absolutely terrified. But we could do it. I know we could do it. Get pledging. Thank you, everyone. You guys are all awesome. And I'll see you very soon.